So I guess we better start. And again, good afternoon. My name is Sherwin Criseno, and I'm from UK. I'm the current chair of the European Society for Endocrinology Nurse Committee, and I'd like to welcome everyone to our very first nurses webinar session. And I know that there are loads of other clinicians joining us today, and I welcome everyone, even the trainees and the doctors who's joining us this evening. We have two excellent speakers today. And just to give you really a brief background of what this webinar session is about, this is designed particularly for nurses, but we welcome everyone to join us in this webinar session. And for nurses in particular, this will provide them a virtual platform to support your ongoing development, particularly in terms of developing your knowledge and skills in endocrinology. And the webinar session will run 3 times a year. And the main focus is to give you a deeper understanding of the different endocrine conditions, but at the same time is also trying to improve and support you in developing your clinical skills in endocrinology by using the Society for Endocrinology UK framework for endocrine nurses. And we're going to talk more about that later on. So every time we have a webinar session, we will have 2 sessions usually. A session that will talk about the disease condition. For today, we're going to be focusing on adrenal insufficiency. And a second section is about the nurse's competency on how you develop the competency on that particular disease condition. The webinar will run 3 times a year. And throughout the webinar, we will be focusing on covering on each of the webinar one of these 13 endocrine conditions that is stated in the Society for Endocrinology Competency Framework. For those of you who are not familiar with this competency framework, throughout our webinar session for the next 12 months, we will talk more about the competency framework and how you can use this in your clinical practice to develop your skills and knowledge in endocrinology. This is currently translated in 4 languages, in French, German, Polish, and Spanish, and you can download this free of charge if you just go to the ESE website, or if you Google Society for Endocrinology Competency Framework, that will take you to the link, and you can download the different languages. And we're working on other languages right now, such as Chinese, Italian, and Turkish, and also Russian. The webinar, as I mentioned earlier, will run 3 times a year. And for those of you who are interested and would like to take note of our future topics, so the next session will be on the 24th of July at the same time, and we'll be covering Cushing's then. And then the 29th of November, we'll be covering osteoporosis at the same time. And just to flag up, this webinar session is free for everyone, even though you're not members of the Society for Endocrinology, really to give you a flavor of what we can offer within the Society for Endocrinology. But there are more that you can get from being a member of the Society for Endocrinology. If you're not a member, we encourage you to look at a membership of the Society for Endocrinology. And particularly for nurses, this will give you loads of support in terms of your professional and personal development. We offer quite a lot of training, and one of these is this webinar session, but there are other bespoke training, particularly for nurses. We also offer training through our yearly congress, and there's a dedicated session for that. And I'll show you the program later on regarding our congress in May. That will give you an opportunity to network and be mentored by experienced endocrine nurses across Europe. And that will also give you an opportunity to collaborate in terms of your research work. So in terms of membership to the society, if you are a nurse and you're a member of your national society, the membership fee is 20 euros only. And if you are a newly qualified endocrine nurse, the membership fee is 10 euros a year. So provided that you are a member of your national endocrine society. And I encourage you to look at the website. There will more information in there regarding the Society for Endocrinology, European Society for Endocrinology in general, and being a nurse member. We have a dedicated web page for that within the ESE portal. And just lastly, before I introduce the speaker, our 25th European Congress of Endocrinology, it will be in 3 weeks' time in Istanbul, Turkey, and I hope to see some of you there. And more information can be found on the ESC website. If you can just type ESC 2023 on Google, and it will give you the link to the ECE Congress, including how to register, registration fee, and the nursing program will also be there, and the entire program to the ECE will be there. So I hope to see some of you at the Congress. Now, without further ado, I'd like to introduce our first speaker for this first webinar. And as I mentioned earlier, we'll be focusing on adrenal insufficiency. Our first speaker is Dr. Helena Gleeson, who is a consultant endocrinologist in Birmingham in UK, and she is also the service lead for endocrinology, diabetes and metabolism, the large tertiary teaching hospital in Birmingham. And she is an expert in the field of adrenal insufficiency, and she will be focusing mainly on optimizing glucocorticoid treatment in patients with adrenal insufficiency. Thank you very much, Dr. Gleeson, for joining us today.
Many thanks, Sherwin, for that introduction. And it's an honor to be at the first ESE nurses webinar. And I very much see the management of adrenal insufficiency as such an important and valuable role that endocrine nurses provide, particularly for the patients that often have so many questions, need so much support in managing this particular aspect of endocrinology. So in preparing this talk, I've drawn on various aspects that will hopefully support your practice. And throughout the talk, there are also questions. We won't be able to gather all your answers, but hopefully as we go through the questions, you can reflect on actually what is your practice before we go on to maybe some of the evidence behind your practice. So just a little bit of background. This is focusing on sort of central adrenal insufficiency. It's not frequent, only affecting between 150 to 280 per million people. A third of patients with pituitary failure may have adrenal insufficiency, but it varies. So you can have pituitary surgery and have an intact adrenal function, or you can have adrenal insufficiency. However, there's some scenarios, such as after craniopharyngioma surgery, where the incidence is going to be high, up to 90%. Then following cranial radiation, you can also have high prevalence if you follow these patients over many years. And we all know that it can be very subtle. So you need a high index of suspicion. You need a real feeling for what patients are at risk and what patients need retesting if they potentially tested normal on the first occasion. And then there's maybe a less well described group, those with mild or partial ACTH deficiency, and certainly during stress, that's when they may actually demonstrate clinical adrenal insufficiency symptoms. So a wide range of awareness is needed for this area of practice. So I've broken down my tips into 5 areas. So firstly, it is making the diagnosis, and particularly in central adrenal insufficiency, the timing of making that diagnosis. Then I'm going to look at optimal glucocorticoid replacement and what the guidelines say and what the evidence is behind those guidelines. Then many of our patients are not solely adrenal insufficient, but they may have other hormone axis deficiencies, whether that be in a primary adrenal insufficiency setting or a central adrenal insufficiency setting. Then our patients also have some special considerations. That might be pregnancy, that might be other medication for other comorbidities, and then something which once again the nurses are key for is that whole idea of empowering patients to prevent and manage their adrenal crisis in those with cortisol deficiency. So let's start at the beginning, making the diagnosis and timing. So firstly, we need to know who's at risk. So patients on long-term glucocorticoids or intermittent glucocorticoids throughout the year, patients who've had things like immunotherapy, patients who've had radiation, patients who've had any form of procedure affecting the hypothalamic pituitary axis, patients with significant autoimmune disease. These are all groups that you'd have a high degree of suspicion. But we know we probably have to screen a number of people because the symptoms and signs are all vague, many of which we might have fatigue. So we need to have our awareness about us. It's well recognized that the 8 to 9 a.m. cortisol can be a useful screening tool, but only if they're greater than 350. This is in our lab. Obviously, people have different cutoffs. 350 nanomoles per liter, we're pretty confident to say it's normal. If it's less than 100, we're pretty confident that they've got a high possibility of having adrenal insufficiency. But there's a huge grey area in between 100 and 350, where many of our patients' cortisol levels will fall. Now, the short-actin test is without doubt the test of choice, whether we're looking at primary adrenal insufficiency or central adrenal insufficiency. But if we look at the diagram on the left, the right, what we're giving is a bolus of ACTH, a much higher dose. It's like squeezing out the pituitary, which is going to directly contact the adrenal glands to see if the adrenal glands are able to produce cortisol. So therefore, in primary adrenal insufficiency, when the damage is at the level of the adrenals, this is clearly the test of choice. However, if we're thinking about central adrenal insufficiency, when we are technically seeing whether the pituitary is working, we can see there's a potential issue here because you are providing the ACTH that the pituitary provide to see if the adrenals would still respond. But it is still a test of choice, and I will go on to talk you through why that is. Similarly, after synthetic glucocorticoids, you need to wait 18 to 24 hours after the last hydrocortisone dose, or even longer for some synthetic glucocorticoids. Okay, so here's a question. So as I've said, there could be a possibility that using the short-actin test to test the hypothalamic pituitary axis may pose an issue. So let's take a scenario where somebody may have developed ACTH deficiency, such as after pituitary surgery. Think about what your practice is how long after surgery would you actually use a short-actin test to assess for adrenal insufficiency. So just have a think. Is it in the first week? Is it after 3 weeks? Is it after 6 weeks? Or is it after 9 weeks? So just have a think or a guess if you're not regularly working with this group of patients. So timing is key post-pituitary insult. One, there are obviously lots of differences in how services manage hydrocortisone. In our practices, patients go home on hydrocortisone. And part of the reason for this is there's recognised to be a morbidity from adrenal insufficiency in the early postoperative period, ranging from around 1% up to 13%, with an overall morbidity of around 5%. So 1 in 20 could have significant problems in the post-operative period from adrenal insufficiency. So to reduce the risk of false negative, and that's what we're trying to do, because clearly if you give somebody a bolus of ACTH soon after they become ACTH deficient, the adrenal glands may still respond. You need to leave a period of time. And the recognized duration of time is 6 weeks. So relatively arbitrary, but 6 weeks is seen as a long enough period of time of ACTH deficiency to result in adrenal atrophy. And this is a study that I did in 2003, where we looked at 153 patients who'd had pituitary surgery. Some of them were excluded. And then of those, I just need to move the little video pictures because I can't see the table. 89 were assessed by short-actin test. Of the 59 that had a normal cortisol, 58 of those passed the short-actin test and 1 failed. and 57 of those remained well. One patient became ACTH deficient. Patient did not have radiotherapy. Of the 30 patients who had a cortisol less than 400, 19 failed the short-actin test and 11 passed the short-actin test. And of those, 10 remained well off hydrocortisone. Once again, one failed. So not completely without some risk, because obviously 2 patients who passed went on to fail without radiotherapy, but relatively good at identifying those who would pass and remain well if they pass the short-actin test. So move on to another scenario. So not only we've done surgery, thinking about radiation, so timing following radiation. The dose of radiation is key. Higher doses, you're more likely to have earlier onset ACTH deficiency. And the recommendation in the guidelines is that these patients require annual checks up to 15 years following radiation and beyond if symptoms occur. So you may screen them with an 8 to 9 a.m. cortisol, depending on the outcome, will depend on whether you go on to do a short-actin test. So that is making the diagnosis and the timing particularly of the short-actin test in the setting of central adrenal insufficiency. We'll now look at what is the optimal glucocorticoid replacement regimen. So just have a think about your own practice. What would you start somebody on? Would you go for once a day? Would you go for twice a day, 3 times a day, or 4 times a day? Just have a little note about what your initial pitch is to the patient about what their hydrocortisone frequency would look like. Next question. What do you practice? Do you look at weight-based or body surface area-based dosing? Or do you just pick a random dose such as 15 milligrams and potentially split it, or 25 milligrams and split it, or 35 milligrams and split it? So make a mental note of what either your practice or your department's practice is. So then let's look at the guidelines. So the central, both from 2016, from the Central Adrenal Insufficiency, the recommendations are to use between 15 to 20 milligrams total daily dose. And it does advise you could use a single dose or you could use a divided dose. And if you're using a divided dose, obviously we often use the highest dose in the morning, the second dose in the afternoon for a 2-dose. If there's 3 dose, second dose around lunchtime, and the third dose in the late afternoon. If we're looking at primary adrenal insufficiency, moving straight to the hydrocortisone, the range of hydrocortisone is slightly wider, so 15 to 25 milligrams. Doesn't consider single dosing appropriate and recommends 2 to 3 daily doses in adults. Obviously, there are some longer acting glucocorticoids becoming more available, and the recommendation is currently, because they're not very available, is use it in selected cases where compliance is an issue for convenience or lack of availability of hydrocortisone. And if we think about what is actually physiological, so in healthy individuals, that's roughly between 5 to 10 milligrams per square meter of body surface area. And then roughly in most adults, that's between 15 and 20 milligrams per day. So that's the evidence base of where these dosing come from. And on the whole, in adults, as opposed to pediatrics, we largely just use a pragmatic estimated dose rather than going down the line of making calculations. Okay, so another question to you. So how do you monitor whether your glucocorticoid replacement in adrenal insufficiency is adequate? Do you do a profile, a serum cortisol profile? Do you do a 24-hour urinary cortisol, also done in Cushing syndrome as part of the diagnosis, but do you use it in adrenal insufficiency? What about patient-reported symptoms and signs? Or do you just start pragmatically the dose and say that's the dose and consider that no monitoring is required? Okay. So can we check? So some researchers have used a cortisol day curve, and some patients are very keen on requesting a cortisol day curve, but it has very little practice in routine clinical use, and we very rarely use it in clinical practice. The only scenarios we might do is if there is genuine concerns about malabsorption in people with intestinal failure, or in where there's concerns of increased steroid metabolic clearance, and sometimes maybe just to convince the patient, but we try not to even to go down that route. Urine free cortisol measurements unfortunately have too wide an inter and intra variability and therefore are rarely useful. So further dose adjustments depend very much on the clinical status, the patient preference and comorbidities. And this involves very much the conversation that we have with our patients on a daily basis, where we try and empower them to actually trial different regimens to see what works best for them, and give them the authority to do that. So this is, unfortunately, there's a yellow box in the middle. So this is a nice schematic diagram. What you can see is with the big dashes, that is our standard hydrocortisone. The small dashes represents the normal circadian rhythm. And then in the background, you've got prednisolone and you've got Plenodron, the long-acting hydrocortisone. And you'll just have to imagine that if we think about our standard hydrocortisone, is that there are times when patients are over-treated or on inappropriate replacement regimens, i.e. we are not as good as what the body would do, and obviously what the long-acting glucocorticoids are trying to do is trying to get closer so we aren't over-replacing or under-replacing at times patients. So what glucocorticoid regimen is best and safest? So this is a comparison between hydrocortisone and prednisolone, and those on hydrocortisone show an improved physical quality of life, but overall quality of life did not differ between those on hydrocortisone or those on prednisolone. And of course, hydrocortisone mimics, is our closest to the natural cortisol hormone produced by our bodies. In a cross-sectional study, those with higher hydrocortisone doses reported adverse health status by validated self-assessment questionnaires, but things like 3 times a day was not superior to twice a day. In quite a large study of hyperpituitary patients, those that received 10 milligrams had the best quality of life, and those who received 25 milligrams had the poorest quality of life. But I'm sure we will all recognize that if patients on 10 milligrams of hydrocortisone who say they're fine, but often patients on 25 milligrams may have gone through several attempts by the healthcare professional to try and optimize their hydrocortisone dose, and therefore by doing so may have ended up on more, but yet their quality of life still remains suboptimal for what they feel is right for them. What about some hard measures? So clearly there is the signs and symptoms, but we know we need to think about what is the significant morbidity that is associated with glucocorticoid replacement. And number one is really around bone health. However, there are very few studies that look at glucocorticoid dose in the range that we're talking about, that look on markers of bone formation and resorption. One of the studies looked at 3 different replacement regimens for 4 weeks and did demonstrate some evidence consistent with direct or indirect suppression of bone remodeling and with suppression of PTH levels. Another couple of studies in men showed that when they looked at 3 commonly used hydrocortisone regimens, so low dose was associated with increased bone formation and positive bone remodeling, and therefore potentially beneficial, whereas over replacement was linked to vertebral fracture risk, despite being adequately replaced with the other hormone very important for bone health, such as testosterone. Another cross-sectional study identified in those on higher doses, once again, a higher rate of vertebral fractures. So that's bone health. What about heart health? So, cardiovascular mortality, so it's been associated, and the greatest risk was in those on higher doses of hydrocortisone. Endothelial dysfunction, likely a direct effect of highly glucocorticoid doses, which may contribute to the cardiovascular mortality. And it's been noted that if you're on lower doses, you have lower arterial stiffness and you have more of a dip in your blood pressure at night, which is normal. So normal blood pressure is higher during the day with a dip at night. And this was observed on those on lower doses, but less so on those on higher doses. Dose reduction may also be associated with clinical improvement, such as body mass index. So going from 20 to 30 milligrams to 10 to 15 milligrams. One study identified a decrease in 7.1 kilos after 6 to 12 months. So really quite impressive. Some of you may be aware that those patients with Cushing's syndromes are at risk of venous thromboembolism, DVTs, pulmonary emboli, and therefore people have looked at whether the dose of hydrocortisone may affect the clotting cascade, but they haven't found that change when they looked at this particular aspect. And this is something else quite interesting. So obviously we're aware of the circadian rhythm, but with that circadian rhythm is a variation in sensitivity. So sensitivity is low overnight and increases through the day, peaking around 8 p.m. And is this important in us getting our dose of glucocorticoids correct and not over replacing or under replacing, and taking into consideration sensitivity? But that's for researchers to advise us on, and people that are looking at the longer acting that are trying to optimize this aspect of glucocorticoid replacement. So another with a square in the middle. So this is the same graph as before. But I think while we are waiting for more evidence and increasing affordability, we need to try and establish patients on the lowest dose that they feel well on, based on the evidence available to us. Okay, so we've covered making the diagnosis, we've covered optimizing glucocorticoid replacement. What about interaction with other hormone axes? So we know that patients with pituitary disease may well be on all sorts of other hormone replacements. And similarly, those with primary adrenal insufficiency could have other autoimmune conditions such as hypothyroidism, premature ovarian insufficiency. So we need to consider the other hormone axes in the context of adrenal insufficiency. So just have a look at that list and have a think about which of these hormone replacements does potentially not have any effect on the diagnosis or management of adrenal insufficiency. So we've got thyroid, growth hormone, diabetes insipidus, or vasopressin deficiency or insufficiency, estrogen replacement, or testosterone replacement. So just make a mental note about which one of those you think is not relevant to adrenal insufficiency, or maybe you think more than one is not relevant. Okay. So let's start with growth hormone. So growth hormone deficiency patients have an increased cortisol, the active steroid, to cortisone, the less active metabolite of cortisol. So, which is partly, why sometimes people say that patients with growth hormone deficiency, a bit of central adiposity, and potentially have that excess cortisol look. However, if you give them growth hormone replacement therapy, this suppresses the conversion of cortisone back to cortisol. And therefore, what you may be doing, because obviously you're suppressing the conversion to the active cortisol, starting growth hormone replacement therapy may potentially uncover adrenal insufficiency, or it may increase glucocorticoid requirements. So having sort of a relatively recent assessment of adrenal insufficiency before starting may be useful, and actually then considering whether you need to alter their glucocorticoid replacement is relevant in patients you're starting on growth hormone replacement. Then there's thyroid. So thyroid hormone accelerates endogenous clearance. You'd have all heard case studies of patients who are been started on levothyroxine prior to having their adrenal status checked, and in that scenario, the patient is potentially at risk of an adrenal crisis, and therefore, in somebody you think that's at risk of adrenal insufficiency, the importance of checking before starting on levothyroxine. What about estrogen? So 95% of circulating cortisol is bound mainly to cortisol binding globulin and to a lesser extent albumin. But it's the unbound cortisol that is the active fraction. Now, oral estrogen increases circulating cortisol binding globulin basically by passing through the liver. And therefore you can have really quite a high total cortisol level. The same effect does not occur with patches or gel, which do not go through the liver. And therefore, if you assess somebody on oral estrogen, you may get a cortisol level that looks reassuringly normal. And therefore, it's important that oral estrogen is discontinued prior to testing for adrenal insufficiency. Then there's diabetes insipidus. So glucocorticoid deficiency impairs free renal water clearance. So therefore, the patient may not be losing water, and therefore that may mask polyuria. And therefore, let's say in a scenario post-pituitary surgery where you potentially may replace hydrocortisone, you also at that point may uncover diabetes insipidus. So the importance of monitoring and understanding if you observe that to happen, and if patients report excess thirst, polyuria, and polydipsia. Conversely, patients with improved diabetes insipidus without adrenal insufficiency, so therefore they've had diabetes insipidus and then it all seems to get a lot better, should undergo assessment for adrenal insufficiency, this is in reverse, is that they may have developed adrenal insufficiency result. And you do find people that have had improved diabetes insipidus, or vasopressin insufficiency, but it's not common. So worthwhile thinking a little bit more in detail about that. So if we think back to our question, the only hormone that I haven't mentioned is testosterone in that area. So we've done making the diagnosis. We've looked at what optimal glucocorticoid replacement is. We looked at interaction with the hormone axes. What about special considerations? So there are a number. So Cushing's. So in studies assessing the recovery of adrenal function after successful treatment for Cushing's disease, then it's recognized that the axis may recover anything up to 2 years out from treatment. So the importance of revisiting and retesting patients that appear to have adrenal insufficiency following treatment for Cushing's. Pituitary apoplexy, because it's an acute adrenal insufficiency, and remember, we would have to wait the 6 weeks before being able to properly check whether they had adrenal insufficiency or not, then glucocorticoid therapy is recommended in those patients until you can thoroughly evaluate their adrenal axis. Then there's some detailed protocols around perioperative management during pituitary surgery, and also for those going for other sorts of operations. And this is once again a core aspect of advice that we give our patients. But what about pregnancy? So making the diagnosis during pregnancy of adrenal insufficiency can be challenging. And during the first trimester, many of the symptoms, hyperemesis, can actually be very difficult to unpick and can actually mimic adrenal insufficiency. Plasma cortisol, similar to what I was talking about with oral estrogen, due to that increased cortisol binding globulin, can be falsely normal in the second and third trimesters. And some people have proposed that there should be normal ranges for cortisol in pregnancy. What about management? So hydrocortisone is the preferred glucocorticoid, in part because it is degraded by the enzyme and therefore does not cross the placenta. Dexamethasone does cross the placenta and therefore should be avoided in pregnancy. Prednisolone is also acceptable in pregnancy. The best regimen is not well defined. It used to be that there was a clear blanket, increase the dose in the third trimester. However, there is more of an approach that we should just be responding to the patient, how well the patient is, and making more patient sort of individual patient adjustments to the dose. Ideally, they should obviously be under a multidisciplinary team, including an endocrine nurse and an endocrinologist. And obviously in the active phase, you're going to treat them as if they're having a significant procedure, 100 milligrams at induction, IV, followed by ideally a continuous infusion or potentially 6-hourly bolus if the infusion is more difficult to deliver safely. Then there are some drugs. So the commonest one affect the enzyme CYP3A4, and in that group you have drugs like anticonvulsants, rifampicin, topiramate, mitotane. And these are the ones that can sort of reduce the level of cortisol, and then although there is no support to make changes, it's about awareness that these drugs in somebody with adrenal insufficiency, patients may need a change in their dose. Conversely, the drugs that actually inhibit the activity of the enzyme, such as antifungals, can actually give people a really nasty iatrogenic Cushing's. And therefore, you need to be aware of that. If patients present with Cushing's, it's important to take that very accurate history of what medication they're on. And antiretrovirals are also known to potentially give you an iatrogenic Cushing syndrome. Okay, so we've covered most of our areas. We're now on preventing and managing adrenal crises. So they can often be initial presenting feature adrenal failure. And actually in central AI or secondary AI, despite having an intact mineralocorticoid function, they can have a similar, if not a higher rate of adrenal crisis. Crisis incident is actually looking for factors of what is likely to influence. And Lisa is more of an expert on this, who's coming next. Studies have not shown that educational status, body mass index, dose, DHEA treatment, age at diagnosis, hypogonadism, hypothyroidism, or GHD give you any way of actually predicting who is more likely to present with an adrenal crisis. There was one study that identified that women and diabetes insipidus was associated with an increase, correlated with an increased risk of hospital admission. So all patients should receive patient education, glucocorticoid adjustment during stressful situation, an emergency card. On the right is our UK version, but there are obviously other versions used across Europe and elsewhere. And obviously you can have bracelets and necklace, and patients are advised to have training in how to administer emergency glucocorticoid. Almost all clinicians should have a good knowledge of managing adrenal crisis, particularly those in primary care, particularly those at the front door, and particularly those that are frequently giving their patients glucocorticoids for other reasons. And the need for immediate glucocorticoid replacement and fluid resuscitation is the same in central adrenal insufficiency as it is in primary adrenal insufficiency. So we've covered the 5 areas that I wanted to highlight as a way of optimizing glucocorticoid replacement. Thank you for listening.
Thank you very much, Dr. Gleason, for that excellent tips on how to optimize glucocorticoid treatment. Just to remind everyone, you can type your question on the Q&A function on your chat box. So we have a couple of questions. The first thing I think is just to clarify, you mentioned earlier regarding the cutoff of 350 for morning cortisol and 100. So someone is just asking to just go over that again. What does 350 mean and what does 100 mean?
So I think the thing to emphasize is that every department in conjunction with their lab have different cutoffs for cortisol. So that's the important thing. So it's very much important to take the question of cutoffs back to your department and your lab. So in our lab, if we do a short synaptin test, greater than 450 or above is a pass. And therefore, when we've looked at our outcome of our short synaptin test against the 9 a.m. cortisol, we recognize that those that have a cortisol of less than 100 have a very high rate of failing the short synaptin test. And those with a cortisol, a random cortisol between 8 and 9 a.m. Of 350 or higher have a very high percentage of passing the short synaptin test. And therefore, certainly in the group with 350 or higher, we do not feel we need to do a short synaptin test in that cohort because the chances of passing is exceptionally high. Whereas those who are less than 100, we'd probably start them on hydrocortisone to keep them safe while planning their short synaptin test. And those between 100 and 350, we would, if we were keen to exclude it, we would proceed potentially, if they were symptomatic with hydrocortisone, we'd start them on hydrocortisone, but if they were okay, we would just proceed to organising a short synaptin test. So I hope that's slightly clearer, but the key thing is the cutoffs are decided locally depending on your assay.
So the next question is, how do you decide when to repeat short synaptin tests on patients with central or secondary adrenal insufficiency? So
if a patient has just had pituitary surgery and they've had their 6-week check and everything, they've passed and they are not going on to have radiotherapy and there's no concerns about apoplexy or tumor regrowth, technically that group should not need a revisit of whether they've got adrenal insufficiency. Except, you know, in the scenarios we talked about, if you're starting sort of growth hormone, those sort of aspects. But on the whole, they shouldn't develop adrenal insufficiency without a reason to develop it. However, clearly if a patient came and said, presented onset of symptoms in keeping with it, you're going to do it because you've got somebody with a pituitary sort of central pathology, so you're going to do it. In cranial radiation, when endocrinopathy, including adrenal, can evolve over time, you are going to embark on some form of annual check of their cortisol status. Now, if they are completely well and their cortisol, then you'll probably be happy that the synaptin test done in 2022, which they passed, they're not complaining of anything, their cortisol's 250, you might say, okay, let's see what it is next year. But in that group, if you would check the 9 a.m. cortisol every year, and then you would decide which ones you would proceed to go on to do a short synaptin test. The other group could also be congenital hypopit. So if they haven't got ACTH deficiency, let's say at the point they transfer to adult services, they are at some risk of having evolving hypopituitarism. So that's a smaller group that you'll be aware of, but that's another group you need to be a little bit aware that they can develop adrenal insufficiency.
Thank you. I think there's someone who's trying to prepare to enjoy the weekend now with alcohol. So the question is, how about alcohol? Does that affect cortisol and cortisol absorption?
No, but I think it's important, particularly in new users of alcohol, to provide them with advice about keeping themselves safe. So the key is, one, that they are with people who are aware that they are adrenal insufficient, and have all the relevant safety. If it's going to be a reasonable night, that they potentially, one, take some hydrocortisone prior to their sort of first drink, so that they have got hydrocortisone on board. But I think the key is that you're with friends who are aware that you do have adrenal insufficiency, and that this is all part of keeping yourself safe, and that you've got hydrocortisone with you, and that you have extra doses that you can take depending on how your evening is going, I suppose. But on the whole, it doesn't affect cortisol or hydrocortisone. Unless you're vomiting, then it will do.
So I guess there's still a few more questions, but I'll ask you one more question, and
Okay.
I hope you can look at the others and probably answer them after that session, if you don't mind. Okay. So another question is, if the patient has a morning cortisol of less than 100, does that mean that you don't have to do short synaptin test and go straight to replacing patients with hydrocortisone?
So technically, I mean, I think, one, you're getting a range of information as well, aren't you? So therefore, less than 100 is a number. If the context is completely in keeping, and your suspicion that this patient has adrenal insufficiency is so high, then, and depending on resources, etc., starting them on hydrocortisone, I think you're pretty safe to do that. Let's say they've got other pituitary hormone deficiencies, they've had an insult, and it's less than 100. I think you're pretty safe to maybe not proceed to short synaptin testing. So I think I would be, if I said they all need short synaptin testing, that is going against what the evidence tells us. However, often we do like to confirm, and often the patients like to have it confirmed as well. So I think that you can argue it both ways. I think maybe it comes down to your clinical suspicion, resources, but I think on the whole, as endocrine nurses and endocrinologists, we often like to confirm.
Thank you. Again, just a brief question here. I think it's very interesting. So is short synaptin test the right test for patients with suspected central adrenal insufficiency? Or is there a better test than short synaptin test for patients with central?
Yeah. So basically, I mean, you know, the synactin test is an incredibly useful test, isn't it? 30 minutes duration, clearly a bit of time prep, and after that, it's a very effective test. And therefore, it is frequently used in central adrenal insufficiency. But it's just that knowledge that if you feel there's been an insult, such as a range of insults, surgery, apoplexy, hypophysitis, you are going to want to leave a duration of 6 weeks before employing it. If for some reason, and let's say you started them on hydrocortisone while waiting for 6 weeks and they became unwell, psychotic, the test to actually look at the hypothalamic pituitary axis is you're looking at the insulin tolerance test or the glucagon stimulation test, which is clearly a far more involved test. But on the whole, the scenarios, you can get away with covering them and then doing the test at 6 weeks after an insult to the pituitary. So I would say, as long as we recognize that it's not directly testing the hypothalamic pituitary axis and we know when to use it and the timing of when to use it, I think it's an excellent test. And it's the test that we probably do the most. Well, we do the most of all our tests, and we love it. So
thank you very much. There are a few more questions, Dr. Gleason, if you have time to answer them directly by responding to those people. And there's still more questions coming in as well. So thank you very much. Clearly a very topical topic in endocrinology. And thank you for those who raised questions. And I'm going to introduce you to the next speaker now, who will then tie in Dr. Gleason's presentation into how we can use the competency framework to develop our skills further in endocrinology and use that in our clinical practice. Our next speaker is an advanced nurse practitioner in endocrinology, Lisa Shepherd, who is also a member of the nurse committee of the UK Society for Endocrinology Nurse Committee. And Lisa has published a few papers on adrenal insufficiency, on adrenal crisis, and also on patient-reported outcomes on patients with adrenal insufficiency. Lisa, thanks for joining us today.
Thank you for the European Society for Endocrinology Nurse Committee for inviting me to present today. So showing says I'm Lisa, I'm endocrine advanced nurse practitioner in Birmingham, and I'm also an NIHR clinical doctoral research fellow, and I'm undertaking research in adrenal insufficiency and prevention of adrenal crisis by developing an intervention. So this is my slide just to claim my conflicts of interest. So basically in this session, I just want to give an overview of the competency framework. Most of you will probably be familiar with it, but it's nice to just have a little look and a bit background to that. The benefits of the competency framework, some new developments that we're undertaking at the moment, and then how it can be utilised in practice. So benefits of the framework. So the competency framework for adult endocrine nursing was first developed back in 2013, which is quite a while ago now. And the reason for this was because there was no standardised competencies at all for endocrine nurses. And as we know, endocrine nurses are quite a rare breed now. And back then we were even more of a rare breed. A lot of nurses are working in isolation, and this just helped to standardise the care. So it was developed by a UK working group of endocrine specialist nurses, and the idea was to enhance the clinical care that adults with endocrine disorders received. The competency framework focuses on both the knowledge, the skills, and the interventions that are relevant to nurses looking after patients with endocrine conditions. And it was envisaged that this document was a useful tool not only for UK nurses, but also nurses working in Europe and globally, although it is recognised there is differences in practice. We went on to do a second version in 2015, which increased the number of competencies up to 13. So in terms of benefits for nurses, it allows us to deliver consistently high standards of care by giving standardised and equitable care between patients in different endocrine centres. So whether you're working as a nurse in one large centre where there's multiple nurses, or whether you're a nurse working in isolation, all nurses are educated and trained and skilled to that same standard, regardless of where you work. It allows us to identify our level of practice and also plan our careers in a more structured way, identifying sort of our educational needs, training development requirements, and how we sort of can progress over time. Therefore, realising our potential more effectively, and also allowing us to opportunities to influence the direction of nursing, both within like our organisations, nationally and also globally. Employers benefit by nurses actually adhering to the competency framework, because they're reassured that we are working to high standards of care, and you know our standard of care is equitable amongst endocrine nurses. So these skills are transferable. If you're going from one endocrine centre to another, then they know that you're working to these competencies. It also allows managers to actually understand what you're doing. I don't know how many of you have got managers who've got no inclination of what endocrinology is, who you know, look after different specialities. So it gives them a good insight into our roles and exactly sort of areas that we need to potentially develop. This can help them assist in organisational and succession planning, looking at different skill mixes and what's needed in individual teams, and also identifying if the teams need to be expanded. Ultimately, this competency framework is developed to benefit patients and the public as well, giving confidence in patients that we're highly skilled practitioners by providing these high standards of care to them. It helps increase effectiveness of service provision, and this is by allowing nurses to develop specialist areas and free up other healthcare practitioners such as doctors who can undertake more complex things. We can undertake nurse-led clinics. So it's actually utilising our skills in the best areas and building up that patient rapport. It also allows patients to build confidence in us, because they can have access to specialist endocrine centres, and they know as nurses we're highly skilled and educated in these areas. And some patients may choose to actually go to certain centres for their care for this reason. So in the second edition of the competency framework, the competency 11 was actually the steroid replacement therapy for disorders of the pituitary and adrenal glands. And we're currently developing a third edition, which the competency is available, but only limited access at the moment. And this competency is now called adrenal insufficiency. So most of you probably have seen Competency 11 from the second edition. For those who haven't, this is what it looks like. So when we developed the competency framework, we built this upon Ben's clinical skills, from developing from a competent practitioner, from a novice to an expert. And we sort of use a similar kind of framework when we were thinking about developing some of the competencies. So the idea is you would come in as a new to endocrinology and the area as a competent practitioner, although potentially you would build these competencies up over time, over the next course, the next few years, and undertaking different education and training. So you become proficient, and then ideally you develop into an expert. So we're currently undertaking and writing our third edition at present, and this structure of the competency framework has actually changed since the second edition. We realise the significance of a lot of clinical nurse specialists are working at advanced practice levels. So we thought it was therefore important to incorporate Health Education England's multi-professional framework for advanced clinical practice. And this is underpinned by the 4 pillars, which is clinical practice being the overarching one, leadership and management, education and research. What we've also done with the 3rd edition is to take into consideration the different skill mix that we now have in the area of endocrinology. A lot of us have healthcare assistants that now work with us. We also teach student nurses, and in some areas we also have nurse associates. And we thought it was quite important to incorporate their needs into this framework as well. So here we can see also following Benner's pathway from novice to expert, we've actually signed healthcare assistants, nursing associates and students to the novice and the advanced beginner as Benner's described. And this goes up to the registered nurses, where we, like I say, was talking about new nurses new into endocrinology, develop them as to be competent, with expectation they would become expert practitioners. So in the 2nd edition, we felt it quite important not to assign bands to these different levels of practice. However, with the 3rd edition, we thought it was more naturally aligned to the bands. So this is what we've incorporated. So this is just looking at the novices competency from the new 3rd edition, just to give you an idea of potentially some of the differences from the 2nd edition. So here you can see the novice is more, needs still an understanding of adrenal insufficiency and steroid replacement, and an awareness of the tests that we use to diagnose adrenal insufficiency. But here we can see it's more of their awareness and their identification of needs for escalation to more senior members of the team, and how they can support us in clinical practice as registered nurses. And also identifying just how important they are to the team for us in terms of clinical skills. They can do either cannulation and blood sampling, and are a fundamental part of the team in this area. And this is why we thought it was important to incorporate them into the competency framework. So when we think about using the competencies, I think the first thing that you need to do is actually to identify the level that you're working at, and see how this potentially the areas and gaps in your knowledge and skills, and how this you can be supported to continue to professionally updated over the course of the next year, the next 5 years, and which direction you want to be headed. So in terms of using the competencies, it's a good idea to look at your level of competence and to actually how that compares to your role expectations. We're all given job descriptions, and what we might actually find as we grow and progress is that our competence level increases far more than what's expected of our role. And it's important then to consider with your managers or your mentors, how this extra expertise that you've developed can be sort of rewarded. Does that mean an upgrade of your band? Are you actually working to your level? Are you underworking on your job description? And what skills do you need to identify to actually be working at your level comfortably? It can show you how you progressed. So you've got your objectives you set at your appraisal, and you can see how you've met these needs and relate it back to your competency framework. Does these tie into the objectives about when your role began? You know, are you achieving these? I think a lot of the time we become quite insecure in our working environments, and we just try to identify and meet the needs of our patients on a day-to-day basis. We don't always actually identify our objectives longer term and how we need to incorporate these into our practice to meet our patients' needs. So those that think you're working at expert level, you know, I say we need to then prove to our managers and to our clinical teams that we are an expert. And we need to start thinking about, regardless of whether you think you're working at expert level or at proficient or competent, you know, why have you chosen that rating? In say, what kind of experience have you got? How can you demonstrate that level of competence? You know, what kind of work do you undertake on a day-to-day basis? You know, do you do nurse-led clinics? What audits and research are you involved with? This doesn't have to be your individual research or audit. This is something you can be part of, you know, with other members of the multidisciplinary team, and it's a good way actually to start your learning how to do these things and develop your experience, so then you're actually undertaking these yourself. You know, can you demonstrate a case study about a patient that you've worked closely with, and what kind of care you've provided? What decisions you actually made? Have you been involved in the development of care pathways? And these are just some examples of how you can develop and demonstrate your levels of competence. So if you still think you're an expert, another way of proving it is by actually doing a self-appraisal via a reflective diary or reflective pieces. You can get verification from others through observed practice, and this might be somebody just watching you undertake a procedure or watch you do a teaching session. What new practical skills have you developed? Is there any evidence that can cover several competencies? So I think the important thing is don't try and take on the competencies all individually. What you will find is a lot of the competencies themselves interlink. So when we talk about adrenal insufficiency, you will find that it will be linked to the dynamic function testing competency, which will then be linked to like hypopituitarism and the other disease areas. So you can use your evidence for more than one competency. So when we talk about how you can meet your competencies, this is just an example that you can use from the NMC. So obviously in the UK, the NMC regulates our practice, and we have to justify every 3 years what we've done to develop ourselves. So if we think about back to that novice, we can think about if they did a reflective account, one of our the senior colleagues did a teaching session regards to dynamic function tests, get them to think about that and write down exactly what they've learned. A good part to do is to actually discuss reflective accounts. So I was talking about a novice is important for doing the observations of our patients. Yeah, and this example just shows you that they had to do a lying standing blood pressure for a patient who's got adrenal insufficiency. They've noticed a postural drop. So they've identified they've got parameters outside the normal. Then what do they actually do about that, and what's the significance of that? They can ask for practice related feedback. They can have their skills observed in taking phlebotomy or cannulation skills, support for dynamic function tests, and as practitioners we can do written accounts to support that. And this applies regardless of whether you're novice through to expert. You can use these types of reflection. In terms of what evidence, can you produce to show your competence? I've just gave some brief examples on the previous slide. Certificates of attendance from courses and training. Obviously, certificates of attendance are very good to provide, but you also need to reflect on actually what you've learned and how you've developed from that learning. Has this resulted in change in practice? Is new evidence-based practice that you're now undertaking because of something that you've attended. Is there any publications you've been involved with, or presentations, or teaching, posters? Say a lot of people get quite concerned about doing this. If you don't feel you can actually do any of these yourselves at the moment, get involved with parts of your team. It's a good way to start, and you'll soon quickly build up that confidence to actually do it yourself. So going on from the third edition of the competency framework that's coming out soon, also for members of the Society for Endocrinology as nurses, and like I say, the European Society nurse members also can become members of the Society for Endocrinology, as Sherwin was saying, for just an extra few pounds. So coming soon for all the members, we'll be purchasing more licenses for this learning platform called Cooper. So this is a mentoring platform that allows us to assign and connect nurses with a mentor or a peer. Like I say, a lot of nurses do work in isolation, and say so. We had feedback that people just needed to be connected more, and this platform allows us to do that. So it's hoped that on the platform we'll have a lot of new training and resources are going to be available for people, and for those who nurses who've got access at the moment. There's instructions actually how to use the Cooper website on there. There's mentorship guidelines, and there's also this personality test where people can undertake. People might have already done it, like the Myers-Briggs personality test, where you can actually complete it and your mentor can complete it to look at your personality types and sort of working with members of your team and how your personalities might interact with different members. On there is some of the new third edition competencies that will be coming, and that goes from novice to expert in some of the competencies at the moment. What it does do is allow you to mark off the steps that you've achieved, and you can upload evidence and discussions that you've actually had, how you've met these steps. And there's also badges of achievement on there as well. So here is just a screenshot showing you an overview of the Cooper website, and this just shows you who's actually logged in. There's a whole mentoring groups and competencies, which is obviously the competency framework. What you can do is you get assigned a mentor will be assigned a mentee, and then you can have different meetings that you set up, and then it discusses different things that you should consider talking about at the mentorship meetings. But obviously you can talk about pretty much anything. You don't have to be standardized by this. So this just shows you the adrenal insufficiency competency, and here you can see there's an overview of what the competency is incorporated, and the different 7 steps that you should achieve to become an expert in adrenal insufficiency. So that's just a little brief overview about the competency framework and new developments that are coming. Happy to take any questions. But thank you for your attention.
Thank you very much, Lisa, for that overview about the competency framework, and particularly how that relates to adrenal insufficiency. So oftentimes we get a lot of email from people regarding job plan and regarding personal specs. So the new edition that Lisa talked about, the edition 3, would probably be helpful for particularly the senior nurses in this group, or the nurse manager, if you're developing an advert, a job plan, or personal specs, because that will be linked to the banding. And just to clarify what Lisa mentioned, the banding of nurses is only in the UK. So in the UK, nurses are banded from band 5 to band 9. So, and the competency framework aligned that. It just can give you an idea on how it should align on the banding, and you can adapt that to your organizations if you work in other parts of the Europe. So you probably have a junior nurse, a senior nurse, and you can align the competency framework on that. So Lisa, the Cooper that you mentioned is very interesting. So can nurses from other parts of Europe, like outside UK, how can they access that? Do they need to be a member of the UK Society for Endocrinology to be able to access that?
Yeah, so they will need to be a member of the Society for Endocrinology. They will have access to it. At the moment, we've just got limited licenses for just so many members to try it, to see how workable it is for people. We've had a few teething problems initially, like setting things up on there, but the idea is that the competencies we put all on there, and it'll be served as like a live document that you can add your evidence to at different times, rather than like the hard copies that we used to. Obviously the third edition will be published as well, as I say, but at least we'll have the benefit of like a live document on there that you can show your progress as you go along. Yeah, so further information will be following how we can do that. We're just trying to sort out more purchasing and more licenses and things, so we'll keep you updated.
Yeah, and for those who are interested in us translating the competency framework in other languages, as I mentioned to you, this is currently available in French, German, Spanish, and Polish, and there are work being done currently to complete the translation in Chinese, in Russian, and Italian. And if there are any languages that you want that to be translated to, you just need to let us know, and we will get the permission from the owner of that framework, which is the UK Society, and they would usually approve that first, and then we usually then start the process of translating it so that it becomes more pertinent to your clinical practice. In terms of the competency framework, Lisa, if they want more training on how to use the competency framework, because particularly those outside the UK might not that be familiar, how can they get support if they're interested in learning more about the competency framework and how to use that in practice?
I say there is sort of information available on the Society for Endocrinology website in terms of the nurses section there, or say they just need to contact the Society for Endocrinology, and then they can be put in touch with one of the nurses there that can help guide them through that.
Excellent. Okay, Lisa, thank you very much again for giving us an overview. And I'd like to thank everyone who joined us today. We have a fantastic numbers who joined us today, just proving that this is really a much needed education platform for nurses. And we're hoping that we can reach out to other nurses outside the main Central Europe, because we would like to reach out to those nurses who don't have the opportunity to develop themselves or attend face-to-face training, either because of financial reason or because of distance. And hopefully our webinar session will give them a platform to have more opportunity for them to develop their knowledge and skills in endocrinology. Our next session is in July the 21st, and we'll be talking about Cushing's. And again, just a last flag up, I'd like to promote again our ECE on the 13th to 16th of May in Istanbul. For those of you who are interested and haven't registered, you will find more information on the ESE website, the European Society for Endocrinology website. And you can either send us a message in there, but registration and all the programs detailed, particularly for nurses, we have 2 days program at the ECE in Istanbul. We have a pre-congress session on the Saturday, which is the 13th of May, that starts at 12 o'clock until 4 o'clock. And we have fantastic session in there where we talk about endocrinology myths, diabetes. And on the main session for nurses will be on the 14th of May, which is a Sunday, where we start at 9 o'clock and finishes at 4 o'clock, a full day session. And you will also find information regarding the award. So last year we launched the European Society Endocrine Nurse Award, and this is open for any endocrine nurses in Europe. If you think you've done something particularly useful, significant, that changed significantly the clinical practice, or improve patient care, improve education of patients or clinicians or nurses, or you've done a really fantastic research that changed significantly any aspect of endocrinology practice, then you can apply for that award. And that award is open for every nurses. And a part of the award is you will be awarded a 1,000 euros plus an invitation to attend next year's Congress with full sponsorship, and of course a plaque of appreciation for that particular award. So more information regarding the Endocrine Nurse Award is on the website. And if you're a member as well for next year, our ECE will be in Stockholm. If you're a member of the ECE, you can avail of the grants that we provide through the society, European Society, like travel grants, but that it's only open for members. So hoping that more of you will become members. And again, I thank you everyone, and hope you have a nice weekend. And I thank the European Society and Endocrinology, particularly to Magda and Claire, for organizing all the logistic behind this webinar session. And most importantly, to our speakers, Dr. Gleason and Lisa, for giving us their time on a Friday evening to talk about adrenal insufficiency. Thank you, everyone. Have a nice weekend.